Common clinical scenario. So there's endless possibilities of what a patient could be coming into the doctor for, whether that be the emergency room, primary care office, a specialty clinic. So I just want to briefly go over some of the most common ones that we're going to see in more of an urgent care ER setting, so that you can know what pieces of information you really need to listen out for while the physician and the patient are interacting. So why do you need to know this? Again, these are just common chief complaints that you may encounter. We'll highlight some factors that you should be thinking about in each instance. So those things that you should be listening to or listening for. Prior knowledge will help you to better collect information for the HPI and the chart in general. There is one YouTube HPI collection practice activity in this PowerPoint, but it's actually also going to be linked in assignment 5, where you'll watch the patient-physician interaction, and I want you to collect the data for an HPI, put down as many physical exam findings as you can, put down an assessment and plan based on what you're viewing. It's just going to be good practice for you. So this common chief complaint of abdominal pain is very tricky from a clinical perspective if you just think about all the things that are in your abdomen. There's a lot of organs, there's a lot of stuff going on. So listening for things like the location of pain, associated symptoms, relevant history, has the patient recently used antibiotics, recent travel, description of stool, is there blood in the stool, are they constipated, are they having diarrhea, a sexual history, if possible, could they be pregnant, when was their last menstrual period, that kind of information. And again, this YouTube link, I don't want you to worry about it too much because this is actually going to be linked in your assignment number 5 for this week. Chief complaint of chest pain. So where is it in the chest? Can they point to it? Is it radiate anywhere? What are the associated symptoms? Diaphoresis, which is sweating, dyspnea, are they short of breath, nausea, dizziness, etc. Does the chest pain worsen with exertion, like when they're walking up the stairs or when they take a deep breath? Do they have any risk factors? Have they had a recent infection? Do they have heart issues? Overall medical history, is it reproducible? And by that, usually you'll see the physician put their fingers where the patient is pointing and be like, okay, does this reproduce the pain? And are there current or previous EKG findings that we're going to pull up for the physician? Things like injuries. What was the mechanism of injury, excuse me, aka how did it happen? Did the person fall? Did they slip? Were they in a car accident? Is the patient on anticoagulants? Obviously, if there was some kind of traumatic injury, we need to know if the patient's blood is thin, because that could be a red flag for possible internal bleeding. Are there other injuries associated? Was there any loss of consciousness? Did they hit their head and then they, quote unquote, passed out? If in a motor vehicle crash, were they the passenger or driver? Were they wearing a seatbelt? Did airbags deploy? Things like headache. Is it a sudden onset headache? Is the patient describing it, worst headache of my life? And I put here this comment, you'll usually get people moving pretty quickly. And it's because this is an indication especially in women, of a subarachnoid hemorrhage. Do they have a history of headaches? Do they have migraines, fevers, neck stiffness, photophobia, meaning that it worsens with light or they can't tolerate light? For patients coming in with stroke-like symptoms, you're going to listen for when was the last known normal. So when did it start? How long have the symptoms been going on? Was only one side of the body affected? Is only one side of the body affected? Were the symptoms precipitated by a headache? So did a headache occur prior to the stroke-like symptoms? And is there any history of hypertension or transischemic attacks? Any other relevant medical history? few other scenarios, bleeding or pain during pregnancy. When was the last menstrual period? Pregnancy history, so gravida, parity, and abortion. So this is generally referring to spontaneous natural abortions or miscarriage, or medical or pharmacological abortions. Gravida is how many times the person's been pregnant, and parity is how many living children they have. Does patient smoke or drink? Any kind of mental health evaluation, you really want to listen for the doctor asking about suicidal ideations and homicidal ideations. If the person says yes, do they have a plan? Do they have a way of completing their plan? And any history of prior attempts or psychiatric admissions. Things like shortness of breath. When did it start? What's their history? Do they smoke? Does it get worse with activity? Are there any other associated symptoms? Have they had contact with somebody who is recently positive for a respiratory infection? As I mentioned, there's going to be a number of clinical scenarios depending on the care area you're in that will apply to you. Again, it's not your job as a medical scribe to ask these questions of the patient. It is just your job to be kind of familiar so that you know what data is relevant to record while you're listening to the encounter. If somebody comes in with chest pain, probably the fact that they stubbed their toe yesterday is not relevant information. So we just want to be as thorough but concise as we can based on that person's chief complaint. And any questions, comments, or concerns, feel free to let me know.